We now will be talking about the lung. One type of exam question that is almost certain to appear in your exam is a question about cancer of the lung. Cancer of the lung kills more patients than any other cancer in the US, including both men and women. Now, the typical exam question on cancer of the lung begins like the one that I'm about to read. On a routine pre-employment physical examination, a chest x-ray is done on a 45-year-old chronic smoker. A coin lesion is found in the upper lobe of the right lung. Well, this might be an older patient who had hemoptysis or an older patient who was short of breath, but the story of lung cancer on an exam question typically begins when the chest x-ray is done and we see a coin lesion. And the question then becomes, is that a cancer? And let me remind you of something that we mentioned apropos of the breast, because it applies here as well. Age is your best predictor. If you are given an exam question where an 18-year-old has a coin lesion, it's extremely unlikely that it would be cancer. If it is a person beyond the age of 60, particularly a chronic smoker, extremely high probability that it be cancer. But to be sure whether a lesion is a cancer or not, we may need to do pretty invasive, expensive diagnostic tests. So if at all possible, we like to avoid those. And I'm going to suggest to you then that if you read this vignette that I just read, if you had that one on the exam, you really got lucky. Because the answer for this one is very, very easy. It's based on the fact that we know that cancer of the lung is a malignancy that grows relentlessly and kills the patient in a few months. And so the thing you want to ask for if you had read this vignette on the exam is, let's look for an older chest x-ray that may have been done in this patient a year or two ago. Because if we find the same coin lesion on that older x-ray, we know it's not cancer. Cancer of the lung would have already killed that patient. And so in this way, you don't have to get into more elaborate decision making as to which is the next test to do. Unfortunately, many times that easy answer will be taken away from you because the stem of the question will already have it. Let me read vignette number 19. A 65-year-old man with a 40-pack-year history of smoking gets a chest x-ray because of persistent cough. A peripheral 2 cm coin lesion is found in the right lung. A chest x-ray taken 2 years ago was normal. They already took away from you the easy answer. Looking for the older x-ray was already done, and in fact, the lesion wasn't there. Which means this is extremely likely to be cancer. Look at all the factors. The guy is older, the guy was a smoker for many years, and that lesion wasn't there 2 years ago. This is not congenital, this is not a benign infection. This is most likely cancer. Well, the next answer that I would suggest to look for, given this particular presentation, would be the one that doesn't yet get into invasive things. It's a good rule on the exam that if there is a non-invasive way to make a diagnosis, we should resort to that before we resort to invasive things. So if you find an answer now offered that says sputum cytology and the CT scan of the chest and upper abdomen, you take that answer. Now, I hasten to add that sputum cytology has a terrible reputation as a test that very often doesn't give you a diagnosis, particularly for a peripheral lesion. It may be more likely to be successful for a central lesion. But you cannot criticize anyone who does that to begin with, because that is non-invasive. And why a CT scan along with that? Because a CT scan, also in a non-invasive way, might show you that there is widespread metastatic disease, in which case the workup doesn't need to be advanced much further, because we do not do palliative surgery for lung cancer. We only attack lung cancer surgically if we think we have a chance to cure it. So again, for the vignette that I just read, if there is an option that reads sputum cytology and CT scan of the chest and upper abdomen is included so the liver metastasis could be detected, you can pick that answer. But if that didn't give the necessary information, or if that wasn't offered, then for the diagnosis of a central lesion, we would have to do bronchoscopy and biopsies. For the diagnosis of a peripheral lesion, we would have to do transthoracic needle biopsies. And if those fail after repeated attempts, the ultimate aggressive way to diagnose a lung cancer would be a thoracotomy and wedge resection, even though nowadays that would probably be done thoracoscopically, but it's still a surgical intervention with wedge resection. But before we undertake those aggressive steps, we have to make sure there are no other factors that would make it inadvisable or unnecessary to proceed with aggressive steps to get a diagnosis. Remember, the diagnosis isn't going to help anybody unless we can do an operation that has a chance of curing the patient. So in some cases, and I'm going to go through examples and eventually through a decision tree to help you remember these. In some cases, we may want to establish first the extent of the disease, because if it is widespread, we cannot hope to cure it with an intervention. And in some other cases, we may need to evaluate first the pulmonary function, because if the operation we are thinking of doing is a pneumonectomy and the pulmonary function is already very compromised, again, we may not be able to do it. Let me go ahead with a number of vignettes, and eventually I'll have a decision tree to review with you, and I think by the end of our review, you'll understand pretty clearly what answer you need to give for these questions about lung cancer. Let me now then read vignette number 20. A 66-year-old man with a 40-pack-year history of smoking gets a chest X-ray because of persistent cough. A peripheral 2 cm coin lesion is found in the right lung. A chest X-ray taken 2 years ago was normal. CT scan shows no calcifications in the mass, no liver metastasis, and no enlarged peribronchial or peritracheal lymph nodes. Sputum cytology, bronchoscopy, and percutaneous needle biopsy have not been diagnostic. The man has good pulmonary function and is otherwise in good health. All right, let's analyze this vignette. Is this man likely to have a cancer? You bet. He's 66, he has smoked like a chimney, he has a lesion now that was not there in an X-ray 2 years ago, and I might even add, when a CT scan shows no calcifications and the mass is more likely to be cancer. So yes, he probably has a cancer. If we treated him, could we cure him? We have a pretty good chance, because the CT scan shows no liver mets, no enlarged peribronchial or peritracheal nodes. And could we do whatever operation was needed? Yes, we can. In fact, he has a peripheral lesion that often can be taken care of with a lobectomy, doesn't need a pneumonectomy. But if he had to have a pneumonectomy, we've been told that he has good pulmonary function, is in good health. So here is an example where we are justified in going all the way to establish a diagnosis. And so the answer on this patient is, let's do a thoracotomy and wedge resection, or do a thoracoscopic wedge resection. Let me now review as an example to contrast. Vignette number 21. A 72-year-old chronic smoker with severe COPD is found to have a central hilar mass on chest X-ray. Sputum cytology establishes a diagnosis of squamous cell carcinoma of the lung. Let me stop there. We already know he's got a cancer. It's the type of lung cancer for which surgery is the therapeutic option. The small cell cancer of the lung we treat with chemo and radiation. But the non-small cell, which includes squamous, adeno, and large cell, we treat with an operation. The operation would have to be a pneumonectomy because this is a central hilar mass. And we were told up front that he has severe COPD. So you know that in this man, the limiting factor may very well turn out to be pulmonary function. And it's appropriate then that we evaluate pulmonary function before we evaluate the extent of the disease. We do that with a FEV1, with a ventilation perfusion scan to determine how much function is given by each lung. And then we figure out what would be the FEV1 that he would be left with if we did the operation. Let's read what the findings were. His forced expiratory volume in 1 second, FEV1, is 1100 ml, and a ventilation perfusion scan shows that 60% of his pulmonary function comes from the affected lung. So we have established that as he is now, with both lungs still in place, his FEV1 is 1100. If we take out the diseased lung, we take out 60% of that. He would be left with 440. The key number to remember is after we do our operation, the patient has to be left with at least 800 FEV1. Therefore, clearly this man is not a surgical candidate. Let's not spend any more money evaluating the extent of his disease. He cannot have an operation. We already have the diagnosis. The cytology did it. He's ready for chemo and radiation as palliative interventions. Let's read the next one. This is now vignette 22. 62-year-old chronic smoker has an episode of hemoptysis. Chest X-ray shows a central hilar mass. Bronchoscopy and biopsy establish a diagnosis of squamous cell carcinoma of the lung. His FEV1 is 2200, and a ventilation perfusion scan shows that 30% of his pulmonary function comes from the affected lung. So could we do a pneumonectomy in this gentleman? Yes, we can. He now has an FEV1 of 2200. We would take away 30% of that. Well, he would be left with plenty function. But this doesn't mean the correct answer is do a pneumonectomy, because you have not yet investigated the extent of the disease. So now he needs a CT scan. If the CT scan clearly says he's got metastases all over the place, he cannot be operated. If the CT scan says everything is fine, we can operate. And if the CT scan is not sure about some of the mediastinal nodes, we would then add a PET scan. If the CT plus the PET scan give us the answer we need, if it says he's got meds, we do not proceed. If they say he doesn't have meds, we do. If that combination still were not to be diagnostic, the ultimate way then to evaluate that is to do what is called a cervical mediastinal exploration or mediastinoscopy, where we pluck little lymph nodes from around the carina via a small incision in the neck to be sure that the carinal nodes do not have metastases. Before I read vignette number 23, let me remind you again of something we just said. We treat non-small cell cancer of the lung with surgery. But we treat small cell cancer of the lung with chemotherapy and radiation. So let me read vignette 23. A 33-year-old woman is undergoing a diagnostic workup because she appears to have Cushing's syndrome. Chest X-ray shows a central 3 cm round mass on the right lung. Bronchoscopy and biopsy confirm a diagnosis of small cell carcinoma of the lung. So now that we have this diagnosis, we do not need to evaluate the extent of the disease or the pulmonary function to see if she could tolerate a pneumonectomy, because we're not going to do a pneumonectomy. The treatment, there are always exceptions to the rule, but the treatment typically would be radiation to the primary tumor, radiation to the brain, and chemotherapy. Well, now that we have then concluded those vignettes, let's go ahead and look at words and pictures on the screen, because this is an extensive topic in which I've already given you information overload, and if we repeat some of these things, it'll be easier to remember them. All right, so now talking about lung cancer, of which you have an example of a specimen in the screen right now. The typical presentation, as we pointed out, is an elderly chronic smoker found to have a coin lesion on a chest X-ray. And if it hasn't already been done, the answer you're looking for is find an older chest X-ray to compare with the present one. Here is a solitary lesion noted on a chest X-ray. And if a new coin lesion appears on the exam, by that I mean this question already tells you it was not there on a previous X-ray. Then if it is offered the option to perform a sputum cytology and a CT scan of the chest and upper abdomen is a reasonable answer, because it is non-invasive. And I'm the first one to admit, as I tell you this, that sputum cytology very often is not rewarding. But if they offer you this choice, nobody could say that's a bad choice, because it's non-invasive. It could be done before we move to invasive things. Now, if sputum cytology is not offered, or you're already told it was done and it was not diagnostic, now we need invasive studies. And then we ought to ask ourselves, are there reasons not to do those invasive and expensive studies? Well, one reason would be if it is widespread disease. The patient has had significant weight loss, he's got palpable supraclavicular nodes, liver function test abnormalities. If you had a vignette like that, you know that that's widespread disease, and then you better start your evaluation with a CT scan. On the other hand, your limiting factor may be pulmonary function. If at the very beginning of the vignette it says the patient has severe COPD, short of breath all the time, he's huffing and puffing, then you realize it is pulmonary function that you have to evaluate first, and you do pulmonary function tests. But on the other hand, if there are no limiting factors, then you proceed with the diagnostic studies. What are those diagnostic studies for lung cancer? For a central hilar lesion, bronchoscopy and biopsies. For a peripheral lesion, transthoracic needle biopsy. If multiple attempts are not diagnostic, a thoracotomy or thoracoscopy and wedge resection. Here's an illustration of bronchoscopy done in a patient with lung cancer. Now, once we have diagnosed lung cancer, if the diagnosis is small cell carcinoma, you can proceed with chemotherapy and radiation. There's no need to evaluate pulmonary function or the extent of the disease. But if it is a non-small cell carcinoma, the other 3 variants of lung cancer, then we have to establish operability. If it is a central lesion that would require pneumonectomy and the presentation suggests limited pulmonary function, the thing you want to do next is check pulmonary function tests. But if it is a peripheral lesion, which is amenable to lobectomy, where function is not an issue, then you begin by evaluating the extent of the disease. Here is an example for you of a Pancoast tumor at the apex of the lung. This is an inoperable lesion. And here is a reminder for you that a peripheral lesion could be resolved with a lobectomy, whereas a central lesion would need a pneumonectomy. So how do we evaluate the function prior to performing a pneumonectomy? We start with FEV1, and we add to that a ventilation perfusion scan, because the latter determines how much function comes from each lung. And then we determine what would the FEV1 if we were to do the pneumonectomy. And it has to be at least 800. How do we evaluate the extent of the disease? We begin with a CT scan of the chest and upper abdomen. The upper abdomen is so that we can check the liver. If the status of the mediastinal nodes cannot be determined by the CT scan alone, we add a PET scan. You know, we haven't talked about PET scan. PET scan is essentially a study that gives you an image of metabolic activity. I know that's a simplification, but it's a good simplification. So if we have a shadow on the CT scan that we do not know, if it is an old big lymph node because there was some inflammatory condition years ago, or it is a big node because it's full of lung cancer, the PET scan will tell you, because a PET scan would show the very high metabolic activity of a growing cancer as opposed to a scar that doesn't have metabolic activity. But if you're still unsure, if even the combination of CT scan and PET scan cannot resolve the issue, then we do a mediastinoscopy, also called cervical mediastinal exploration, to check the carinal nodes. If there is disease in the carinal nodes, we should not proceed. Now, for non-small cell carcinoma, before surgery is performed, then 3 things are required. I'm repeating now. This is a summary of the summary. What are the 3 things we need before we operate in a non-small cell cancer of the lung? We need tissue diagnosis. We need assurance that the operation will leave the patient with enough pulmonary function, and we need assurance that there is no metastasis in the liver, the opposite lung, or nodes around the carina. And that's the end of our review of the lung.